Have you ever waited in a busy ER waiting room with a sick loved one, child, or yourself being sick and wondered why? Why am I waiting for care? This is an emergency. Hi, I'm Jeff Dreher. I'm an emergency physician and operations expert, and I'm here to talk to you about why patients wait for care and how we have successfully removed it. In the next 15 minutes, I will explore the problem and tell you about a solution that improves efficiency and satisfaction for both patients and staff. And we need a solution. Waiting for care causes harm. This is the very unfortunate case. This is a high school senior who had a full ride scholarship to an Ivy League school and a promising future as an Olympic hopeful. One day while rowing, he developed a scratch, a minor scratch on the back of his leg, and over the weekend, this scratch worsened. He went to the ER on a Monday at noon, where he waited. He waited for care for over 12 hours. And that scratch was not a minor problem. He had necrotizing fasciitis, the flesh-eating bacteria, and the treatment for this is amputation. He underwent multiple amputations. He left the hospital 6 months later with no legs. This should never happen to anyone. This is why we need to fix this problem. But how do we fix this problem? Here's our current reality. We know patients wait for care. We know our EDs are overcrowded. We're boarding patients and we're diverting squads. Care is delayed. Quality suffers. Staff is burning out. We have a high bed occupancy rate and our hospitals have a low operating profit margin. We know about all these problems as frontline staff, but I bet you didn't know that your hospital revenue is running low and we're having low profits. During my career as an emergency physician working on quality and performance improvement projects, I've successfully been part of teams that improve the care of AMI, sepsis, and stroke. But, and that's a big but, we have been unsuccessful at proving ED boarding, ambulance diversion, and staffing issues. We've used Lean and Six Sigma, but Lean and Six Sigma doesn't work on boarding, amp diversion, or staff burnout. And the overcrowding, the boarding and diversion, these problems are chronic and been going on for 38 years. And it's not from a lack of trying. Since 2000, hospitals have been using Lean and Six Sigma, but they've not proven successful in solving these problems, even though they're great methodologies. We need a new way of looking at this so that we can solve our problems. And I'm going to show you how we solve this. I'm going to make it crystal clear. When I started looking into this problem further, I actually realized there's a causal relationship between all the variables we talked about. Hospital profits are low, which causes hospital administrators to run at a high hospital occupancy rate, which then causes patients to wait to care. Now, this is a very interesting relationship, and I'm going to show you more about these in a different slide. But waiting for care causes delayed treatment, and quality then suffers. And the ED backs up because patients are waiting and our ED and our beds are filling up. So we have overcrowding, boarding diversion, and burnout. And this further causes problems. When you have delay in care, it actually decreases the profit you make from each patient, increase the cost of health care. So the hospital revenues actually drop more, and this is an unending cycle. In fact, over the years, this problem has just snowballed. And as it rolls down the hill, it just gets bigger and bigger and bigger. And hospital administrators are kept scrambling, trying to figure out how can we increase our profits. They're low already. They're only 2 to 4%, and they're highly variable. So this cycle began when payment for patient care actually changed. Prior to 1983, hospitals were paid by a fee-for-service basis, but in 83, it went to a DRG base, where the payments were predetermined and fixed, and it was value-based. Because this happened, hospital margins went down dramatically. Before this, they were really robust, but after this, they were down. And because of this, hospital administrators had to look at where can we cut costs. I was actually shocked when I saw this slide. It is the percentage of hospitals that had a negative annual operating profit margin, and it ranged between 30% and 53% of the hospitals had a negative profit margin between 1995 and 2022. This is why hospital administrators are so financially conscious and why any solution we have has to be financially conscious. So this yellow box shows the median hospital operating profit margin during times of stress. 2%, 3.3%, and 0.8%, all very low. And so operating profit margin is extremely important because it allows us to innovate, educate, reward our staff, add community services that may not be profitable. It's extremely important for the stability of a hospital. When empty positions come open, they can fill them immediately if they actually have a profit margin. So a profit margin is extremely important. So with profit margins being low, administrators must strive to maintain profitability of their organizations. So what do? Well, the financial department gets together, the CEO, CFO, and the rev cycle people, and they take a look at the balance sheet. And basically it has the revenue we bring in from hospital operations, the expenses that we have in delivering that care, and what is left over is the net profit. So they take a look at all of these categories and they find out that some of these costs are fixed, such as supplies, utilities, maintenance, and insurance. And in fact, these costs are rising. And then they see that there's a huge chunk of the operating expenses that is actually staffing. 48 to 56% of the cost is staffing. So they take a look. How can we change or manipulate or optimize staffing in order to make our hospital more profitable? Administrators control staffing levels to ensure profitability. They will vary the number of beds in the hospital that are open. An open bed is a staffed bed. So based on the number of patients, that is the census of the hospital, administrators will vary the number of staff, particularly the nurses, to keep the hospital occupancy rate above 85%. The graph on the right depicts this. When they go below 85%, it seems that they are not making a profit. So why 85%? It seems to be the point of profitability. One day the ER was particularly busy with over 20 patients in the lobby at 2 o'clock, and we were short-staffed. So I went to the CNO to see if she could help us out. So while walking to the administrative suite, I ran into Mr. Lewis, our president, who was in a rare good mood. "You're in a good mood," I said. He said, "We're over 90% occupied. I know we're in the black." No lie, my jaw fell open. So keeping the hospital occupancy rate high is causing my patients to wait for care. How does this happen? I'll show you on the next several slides how exactly this happens. So this slide for me is an eye-opener. It's how occupancy rate causes waiting. So the chart on the right is actually much like the law of gravity. As you increase occupancy rate or utilization of any resource, wait time increases. Initially gradually, then once you hit 80%, it actually shoots up like a rock. And this is how occupancy rate and profitability is causing waiting. So any solution we have is going to have to be creative. We're going to have to think outside the box. We're going to have to work together as a hospital system, as a team, in order to utilize our resources better, to help each other out, to solve our problems. So clearly, occupancy rate is related to waiting for care. And waiting for care causes delays in treatment. For stroke, sepsis, any disease that you wait for care causes quality to suffer. So everyone knows that if we can get to you quickly, speed to care drives quality. And a heart attack victim, every 30-minute delay increases your mortality by 7.5%. With stroke, any delay causes your brain to be more damaged. And with rapid treatment, you'll be able to go home and go back to work. However, if care is delayed, it's never a good thing. So needless to say, delayed care gives you a poor outcome. With heart attack, you can end up with CHF, which decreases your 5-year lifespan as well as decreases your quality of life. With stroke, most likely you're going to end up hemiparetic, can't walk, can't talk. You might go to an ECF wearing a drool pad and a diaper, not a good quality of life. And with sepsis, our mortality rate is already 30%. That's with the best treatment. So this young gentleman's life was totally changed with this event, and as well as the staff. When you take care of people with a bad outcome, and it's boy, if we could have gotten to them sooner, if our system had ran better, if I didn't have so many borders blocking up the ED, maybe I could have seen these patients. This is what's causing stress and burnout. And working in a chaotic, overcrowded environment that's harming our patients causes the staff to burn out. That's why we're having staff shortages. Can you imagine what it feels like to work in a place like this with too many patients, too little staff, and not enough rooms? And patient care becomes whack-a-mole with only the most critical things being addressed. I've heard many a nurse say, I didn't go into nursing to care for patients like this. And the result of the overcrowding, boarding, diversion, staff burnout, staff turnover, things like that is causing us to have financial losses, and it causes the cost of healthcare to increase, which further perpetuates this entire vicious cycle. So hospitals are operating like this, and they have an operating profit margin of 2 to 4%, and a lot of them are running in the negative. But what you need to realize is there is a cost to operating hospitals like this, and it's called the cost of lost opportunity. So when patients walk out 10 a day, it's about $3 million in lost net profit. That's the cream of the crop money. When we divert ambulances, we have turnover, quality suffers, market share losses. It all adds up to about $11 million of lost net profit annually. And we need to really consider this when we look at how we operate hospitals and why we operate hospitals the way we do. So we know how this all occurred, but the real question is, what is the solution? What can we possibly do in this system that is so messed up to fix this? Well, any solution must be financially viable. It must increase revenue because our operating profit margins are so low, and administration won't go for anything that's not going to make financial sense. It must be a system solution because the system is what is causing this. It's not just one department or one variable. There's a lot of things, and it's with the variability, we need everyone involved, which means the system needs to be involved. And it must fit with the mission, with their organizational mission statement. It must promote flow. And in order to do that, you've got to remove bottlenecks. Flow is not going on because there are bottlenecks, and everyone will tell you there's bottlenecks in our system. It needs to be leadership driven because we need leaders to be involved in this so that it actually sticks. And we also need it to be rapid. We've been dealing with slow results for a very long time, 38 years, and we're frankly sick of process improvement efforts. We need a rapid result, one that happens within 3 to 6 months so that we can see the results and celebrate. So performance improvement's been around quite a long time in healthcare, and what we've noticed is that you can improve things locally or globally. And the thing is that we've improved things locally, but not really attempted to improve things globally. That is, improve the system. So about the TOC, that is great is that it looks at it from a system standpoint. It looks at not at the trees, but looks at the forest and says, what is the goal of the system? And this is in every mission statement of every hospital I know. It's to take the greatest care of people all the time. Our patients are priority. And so we need to do this by identifying the constraint. Pretty simple because our frontline staff will tell you we need more staff and more beds. But we know that's going to cost more money. So what we need to do is to improve the efficiency of the constraint and promote flow. How do we do this? We never let it remain idle. We improve its efficiency, we improve its turnover, and we promote flow. We have put all of our performance improvement people on just the constraint because I can improve everything else, but it will not improve the throughput of the system. And throughput is what we need because that increases capacity. It's the only thing that increases capacity. Decreasing the length of stay improves your capacity dramatically. We need to put metrics in place that measure throughput, and they focus on it. And we need to change our mindset on management. We need to focus management on the constraint, not on each department of the hospital, but on the overall system and what is the constraint of the system. And the beauty of this is if you do this, you're going to improve flow through your whole system. And even in complex systems, there's only a few bottlenecks. So efforts must first be put on the constraint. It results in enhanced system flow and improvement of the entire system. And I'm going to show you the results of what we did at a hospital and improved this. So we focused on the constraint. Whenever the ED started to get backed up or whenever we started to have boarders, we actually took action to make sure that the beds were fully occupied and being utilized. We moved patients upstairs when they were admitted and had a bed. We discharged patients when they had a discharge order, and we moved psych to the psych unit. So by doing so and acting in a live environment, we actually decreased the admission length of stay for the ED patients by 2 hours and decreased the discharge length of stay by an hour. And when you do this for 230 patients a day, it actually adds staffed bed time. It's like dropping a fully staffed 12-bed ED pod into your emergency department. At the end of this project, things were a lot less chaotic. We were able to see more patients. We increased our capacity by improving our throughput. The left without being seen dropped from 40 patients a day to 4 a day. And that surprisingly add 9% to the overall profit of the hospital. Quite an amazing project and quite amazing results. All the metrics improved, including Press-Ganey scores. I've never seen this happen, a 10-point jump over 60 months to a year, and it's sustained. So this can be done, this can be reduplicated. By looking at the process and looking at the whole system and getting management involved in managing backups, things can be dramatically and rapidly improved. Well, that was a brief introduction into how and why we need to fix things. Here is my contact information if you have any questions at all. Here's my YouTube channel. I have more videos on there if you need more information. My next video will go through a step-by-step process on how you actually implement TOC and how you use Lean and Six Sigma integrated into that, as well as queuing theory, to really fast pace your improvement and get your ER and your hospital in order. And actually this helps create buy-in for change. I'm also presenting this at the TOC conference in Las Vegas in October. Look forward to seeing you there. Just look at it at toc.org.